Hello, my name is Mark. I would like to take a moment to talk about my research into the right to repair. As a consumer, when we buy a piece of equipment, the ownership of that equipment transfers from the vendor to the consumer that bought the equipment. For example, you buy a cell phone. The cell phone works great for a couple of years, but then it breaks. You own that cell phone, but in order to get that cell phone repaired, quite frequently you have to send it back to the manufacturer for repair. As a consumer, you don't have access to the information, the tools, or the parts required to repair that cell phone. The same thing happens in the medical field. A hospital buys a piece of equipment, let's say an x-ray machine. The x-ray machine fails, or they buy a ventilator, and a ventilator fails. Quite frequently, the vendors protect their equipment and do not always provide information for the consumer to fix that equipment. In cases like this, the consumer quite frequently has to rely on high-end service contracts or high time and material cost in order to repair that equipment. So the right repair is designed to address these kind of scenarios. Many vendors are concerned as to whether or not the repair person has the ability to adequately and safely fix the medical equipment. I've been in the biomedical repair field for over 18 years, and there have been many occasions when we have wanted to repair our own equipment in-house, but have not been able to do so because of lack of information. So this prompted me to write a question on my research about, is it possible, when access to the qualified information and data is available, can our biomed equipment repair technicians or healthcare technology professionals perform timely and cost-effective repairs to hospital-owned medical equipment without sacrificing the quality of repairs or safety for the patient? So as I started reading the data and conducting the reviews, the literature review, I found three primary questions to address this bigger question. After defining three additional questions to answer the bigger question, I pulled some quantifiable data from a hospital and broke down a repair program to see if we could find a solution or an answer to the bigger question. The hospital reviewed had over 10,500 pieces of equipment, and about 6 years ago, they took a major shift in strategy and moved from a full service contract position to an in-house repair program. So the data I reviewed took one service line in particular, imaging equipment, but I also reviewed a specific vendor that is able to provide training to our in-house teams. And I broke down the data and came across some very interesting scenarios. The first question I asked was, can medical equipment be repaired without sacrificing patient safety? So the chart you see on the screen in front of you shows 6 years of data. Knowing that there was a shift in data in 2013, or that's when the service strategy took place, we can see that the number of pieces of equipment on average increased from 2014 to 2019 compared to the prior time frame. When we looked at operator errors, when we looked at damaged equipment, when we looked at patient incidences, and we looked at hazard alerts, as you can see on the right side of the chart, the numbers stayed fairly consistent. Now, we did have but we changed strategies and found a better way of recording what we were finding during repairs. And some of those findings were probably not identified prior to the service change because the vendors were doing all of the work. But in general, the number of safety events and the ability for the in-house crew to repair equipment safely stayed pretty much the same straight across the board. The second question I looked at was, can an organization decrease the downtime of broken equipment? In other words, can an organization repair equipment faster and more efficient? And once again, looking at the total days of equipment from the years 2018 to 2013, we averaged 210 days of recorded equipment downtime. That was downtime based on waiting for vendors to come in and service the equipment. So from 2014 to 2019 then, yes, the number of equipment counts went up. Our number of repairs went down slightly, but we saw a huge decrease in the days recorded downtime. In other words, we saw 112 days of downtime versus the 210. And when we look at that data, that equates to about a 46% decrease in downtime for this equipment. Now, this is reviewing 3,360 service events against this equipment. That's PMs, which is preventive maintenance, and repairs. So this evidence indicates that an in-house team, when fully qualified, can significantly decrease the amount of time equipment is broken and the amount of time equipment is out of service. The third question I looked at, is it possible to reduce the overall cost of equipment maintenance utilizing an in-house repair team? And once again, using the same 6 years of data, actually 12 years of data, 6 years prior to the change and 6 years post-change, we see some interesting numbers. We can see after the strategy change occurred that we did see a small increase in the repair time and material cost. We saw an increase in the time and material cost related to preventive maintenance. And that's kind of to be expected because as we reduce service contracts, we would expect our in-house costs to increase. But look at the contract costs. The contract costs dropped from 2.2 million to 734,000. So when you do the calculation, we were able to save in the second time period, we were able to actually decrease the financial impact and the cost of the equipment by 53%. So this is very indicative of the fact that an in-house clinical engineering team, when well trained, can reduce the overall service costs on the equipment service line. So to recap, safety had very little change. The in-house team was able to decrease downtime by 46%. And an in-house team was able to reduce the financial impact to the organization by 53%. And this is just reflective of one service line. So the question is, where do we go from here with this kind of data? Well, there's a movement nationally on the right to repair to find ways of providing access and gaining access for our in-house teams to have access to the information required. So a couple of things. One, our organizations need to join hands. Our organizations, not only with our private hospitals, our public hospitals, but our other organizations, repair organizations, need to come together and work with legislation, put legislation together, work with the teams with the pertinent data, as we've just demonstrated, and work with our vendors then to help create laws and legislation to allow access to the information required for our hospital repair teams to fix the equipment that they've already owned. Thank you.